Management of postoperative nausea and vomiting, PONV. Postoperative nausea and vomiting is the cause of noteworthy malaise among the postoperative patient population. The Australian and New Zealand College of Anaesthetists 2012 found that in these two countries, postoperative nausea and vomiting occurs in up to 30% of the general surgical population and up to 80% in high-risk surgical patients. Additionally, Gan et al. 2014 has linked PONV to unforeseen admissions of day surgery patients to the hospital, a rise in a patient's discomfort level, mobilization and discharge setbacks, and overall patient discontent with the surgical experience. While nausea does increase the anxiety level in patients, postoperative vomiting can lead to more dire complications such as aspiration, dehydration, and wound dehiscence, to name just a few. In a recent study by Apfel et al. 2012, patients aged 50 or younger were found to be at an increased risk for PONV. Other key risk factors include the female gender, past history of motion sickness or a non-smoker status, past history of PONV as a result of opioid use, certain surgical procedures such as laparoscopic or head and neck surgeries, and the use of some volatile agents used in anesthesia. A pain assessment of a patient should include questioning the patient about a history of nausea. Indicative signs include tachycardia, dilated pupils, increased salivation, diaphoresis, and pallor. If a patient is showing signs of nausea, it is important for the nurse to remain nearby because the patient is at risk of aspirating any vomitus that may occur. If the patient does vomit, the nurse should chart the quantity and vomit characteristics. Post-anesthesia, while the patient is still drowsy, care should be taken to avoid aspiration of vomit. Bedside suction apparatus should be available for the patient, as well as turning the head of the patient to the side as a precaution to avoid aspiration. Other nursing interventions recommended in Brown et al. 2015 for a patient experiencing nausea are to encourage the patient to take deep breaths, placing the patient in a high Fowler's position, offering mouth care, and placing a cool cloth on the forehead of the patient, all of which may aid in comfort. A vomit receptacle should be made available, and the nurse should talk to the patient in a reassuring tone. Gan et al. 2014 determined that many factors contribute to a patient experiencing PONV, with many of these factors largely out of the control of the patient. Anesthesia-related products that do aid in the causation of PONV and can be controlled by the anesthetist can be minimized. These agents include volatile anesthesia, nitrous oxide, and the use of postoperative opioids. PONV is significantly affected by opioid consumption. A recent study by Roberts et al. 2005 found a consistent 6% decrease in postoperative vomiting being obtained when the postoperative opioid dose was reduced by half. Recent guidelines highlighted by Apfel et al. 2004 recommend the use of antiemetics to combat PONV. Ondansetron, known by the brand name Zofran, is the gold standard of antiemetics today. However, as with any drug, administering an antiemetic carries a risk. A recent study by Charbit et al. 2005 found complications could range from a headache to a more sinister prolongation of the QT interval, indicating a possible ventricular arrhythmia. A risk assessment should be conducted on all patients prior to administering any antiemetic. Gan et al. 2014 recommend the Apfel Simplified Risk Score be utilized to determine a patient's risk for PONV. The risk score by Apfel is based on 4 predictors: being female, a history of PONV or motion sickness, being a non-smoker, and the use of postoperative opioids. Several non-pharmacological methods for decreasing PONV were analyzed by Gan et al. 2014, which found music therapy, inhalation of isopropyl alcohol, intraoperative gastric decompression, proton pump inhibitors, and the administration of the nicotine patch to non-smokers to all be non-effective in PONV prophylaxis. However, a study by Lee and Fan 2009 into non-pharmacologic methods, such as stimulating the P6 acupuncture point on the wrist, have recently been found to be as effective as prophylactic antiemetics in reducing PONV. In a recent study by Maharaj et al. 2005, a decrease in PONV in surgical patients has occurred when suitable intravenous fluid hydration levels were obtained. In another study highlighted by Gan et al. 2014, naloxone in low doses has been proven to reduce PONV in adults and was shown to greatly reduce opioid-related adverse effects such as nausea in both children and adolescents. Lastly, Gan et al. 2014 pointed to a recent meta-analysis that determined ginger provides effective care in PONV prophylaxis with a fixed dose being administered 1 hour prior to induction of anesthesia. The Gan et al. Consensus guidelines show that in recent years, antiemetic drug costs have decreased dramatically. This is due to generic brands becoming available. These guidelines indicate that prophylaxis is cost-effective when more established and less costly drugs are administered to patients who have a 10% or more risk of emesis. So why does PONV remain unsuitably treated in the hospital setting? Numerous studies have been conducted regarding PONV, which has provided an outstanding level of evidence to guide clinical practice. Gan et al. 2014 claimed the biggest hurdle appears to be the failure of anesthesia providers to incorporate this knowledge into clinical practice changes. In order to get PONV more suitably treated in the hospital setting, it is recommended that the risks and benefits of prophylaxis be underscored as having a high level of clinical importance. Gan et al. 2014 state that obtaining more accurate data on the prevalence of PONV and the resulting clinical and psychological fallout from nausea and vomiting will aid in improving changes to practice and more widespread adherence to evidence-based practice guidelines. The consensus guidelines found too many PONV studies to be redundant, with the expert panel strongly suggesting not continuing down this pathway. The study concluded that a management strategy for antiemetic prophylaxis be utilized for each patient, taking into account patient preference, cost effectiveness, and level of PONV risk.